Good day, and thank you for attending this webinar titled 3D Printing for Vascular Imaging. Before we begin, please note the Q&A button at the bottom of your screen. To submit a question to our presenters, click the button to open the Q&A window, type in your question, and then click the Submit button. The moderators and other attendees will see your questions, and the moderators will select questions that will be answered by our presenters. The Q&A segment for tonight's webinar will occur after the presentations, but we encourage you to submit your questions at any time during the presentations. And now, to begin the webinar, we welcome from Michigan State University, Dr. Judith Lin. Dr. Lin, the screen is yours.
Hello, everyone. I welcome you all to today's webinar on 3D printing for vascular imaging, sponsored by the Society for Vascular Surgery Health Information Technology Committee. I'm a vascular surgeon and currently the professor and chief of vascular surgery at Michigan State University College of Human Medicine in East Lansing, Michigan. 3D printing are becoming an essential tool in the workplace for many businesses and industries, including medicine and healthcare. Technology is evolving fast and is now possible to print three-dimensional objects, which were unheard of 10 years ago. My co-moderator today is Dr. Dan Kasavan. Dr. Kasavan is a vascular surgeon and member of the SVS Health IT Committee. And as usual, this webinar will be converted to audible bleeding podcast for future listening next month by Dr. Adam Johnson. Dr. Johnson is an international fellow at the Royal Infirmary of Edinburgh, as well as the managing editor of Audible Bleeding.
So our presenters this evening are Thomas Carruthers, Stacy Fisher, Jeffrey Hirsch, and Nicholas Osborne. Dr. Thomas Carruthers is a vascular surgeon at Brown Surgical Associates in Providence, Rhode Island, and the Providence VA Medical Center. Dr. Stacy Fisher is a cardiologist, associate director for the Adult Congenital Heart Disease Center, and associate professor of medicine at Johns Hopkins Medicine in Columbia, Maryland. Dr. Jeffrey Hirsch is a radiology and assistant professor at the University of Maryland School of Medicine, Baltimore, Maryland. And Dr. Nicholas Osborne is a vascular surgeon and associate professor at the University of Michigan Health in Ann Arbor, Michigan. Please remember to use the Q&A button at the bottom of the Zoom screen to submit your questions to our panelists. Okay, let us get started. Now I'll pass the program to our first presenter, Dr. Thomas Carruthers. Dr. Carruthers, the screen is yours.
Good evening. Share my screen here. All right. Can everyone see my screen? All right.
Yes.
Great. So, as it was stated, my name is Dr. Carruthers. I'm at Brown University. I'm going to be talking about a kind of overview of 3D printing, kind of my introduction to 3D printing, and then kind of do a demo of how we can create a model from a CT scan and then print it, mainly using consumer grade printers and materials that are available almost to anybody. So I have a clinical focus in wound care, venous disease, non-invasive vascular imaging, and I have a background in computer science, which helps me with a lot of this 3D modeling and 3D printing. My interest in 3D design and printing started pretty much as a hobby with designing tools for some of my hobby woodworking, some kind of poor attempts at art, and then also having some fun with my kids. But then March 2020, at the start of the pandemic, my skills were kind of put into use in the medical field. As we all know, there was a PPE shortage, and the 3D printing community really mobilized very quickly to start making designs available for 3D printed face shields, for ear protectors, things like that. But as this went on, as the weeks went on, there were discussions and explorations about making actual 3D printed masks. And the problem with this is most of the materials that you use in a 3D printer are quite hard, and trying to put that on your face, you would potentially end up with pressure ulcers. There's problems with sterilizability and whatnot. So I joined a group at Lifespan and Brown University where instead of trying to 3D print the mask, we came up with a design where we made a mold, basically a negative of the mask, and that we could then cast using silicone. We printed out these molds and set up basically a little assembly line at the Brown Design Workshop on the main campus, and we recruited a whole bunch of underutilized medical students, and we made a couple hundred of these things. And along with that, made some custom filter housings to try and use expired N95 material because the N95 material was so in scarce supply. In the end, it worked out pretty well. We sent it off for NIOSH testing, and it turned out to only be N89.5, which doesn't quite have the ring of N95, but it was a good effort. It was we learned a whole lot as part of the process. So 3D printing, if you're not familiar, is an additive process. So when you're creating something, manufacturing something, there's additive and subtractive. And subtractive, you imagine a sculptor. So you got Michelangelo with a giant block of stone and then chips away to find the statue beneath. Whereas additive, you take component parts or materials and then build that up. And 3D printing, for the most part, is an additive process. There are a whole bunch of different technologies. FDM is fused deposition modeling, which is what I'm going to be focusing on. It is the most consumer available. It's the kind of cheapest, and it's frankly the one that I have the most experience with. There are more advanced techniques, vat polymerization. The one that is most common that I'm aware of is SLA. Powder bed fusion, where you can actually make metal parts, and then material jetting. I believe some of the presenters after me will be at least talking some about some of those more advanced techniques, the SLA and material jetting. As I mentioned, FDM is affordable. The machines are sub $1,000. You can get ones for a couple $100. Whereas SLA starts getting into the thousands of dollars, and material jetting is on the order of hundreds of thousands of dollars last I checked. FDM printing is basically like an inkjet, but in 3 dimensions. You have to start with a digital model, a representation of what you want to print. You then have to load that model into software that slices it into layers. And then these layers, which are, you customize the parameters of how thick the layer, so you want what type of material you want to do, and then you send those instructions to the printer. And the printer will have a video demonstration of it in a little bit, but again, is like an inkjet printer in that the print head goes left and right, which is the x-axis. The y-axis would be the paper moving in, but in this case, the paper can move in and out. And then the z-axis is the print head moving up as the model gets taller and taller. So as part of this, I'm going to be talking about steps that you can do, anyone can do to create a 3D print from vascular imaging. And this is all freely available software, open source, downloadable software that you can get freely. The basic steps are you have to start with a solid. So in this case, in the actual medical thing, you have to start with the patient. So we have our patient there, and you order a CT scan for him. So he runs through the CT scanner, and you end up with slices of the patients. So we're all familiar with that terminology: CT slices, 1 millimeter, 2 millimeter cuts, etc. So when you do that, you then want to go back to a model or a solid, in this case, a digital model, where you want to extract some feature of interest in the CT scan. In our case, we're looking at an aortic aneurysm right there. It's obviously applicable to many other fields, liver, tumors, kidneys, the brain, whatever. But from those source slices, you create this 3D model. And then a little counterintuitively, you then have to slice it again. So you sliced something, reassemble it, and now you're slicing it in order to create the instructions for the 3D printer. And then from there, you send that and end up with your 3D model right there. So to get to the slicing step, so the free software is called Slicer 3D. Like I said, it is open source. I'm going to show you just a quick little demo of it here. It should look familiar to anybody who has reviewed CT scans. You have your axial, your coronal, your sagittal views. You have your the crosshairs to correlate between the views. But using a number of these tools here, mainly in the segment editor, you identify areas in the scan of interest. And so to identify the aorta, used a technique that just does threshold monitoring, basically based on the Hounsfield units, and it automatically creates that 3D model. For the thrombus, which you see is in a different color and is a different part of the model there, you have to use a different technique called image seeding. But it seems a little complicated, but just learned, I just learned it by watching tutorials on YouTube and was able to create this model in about 10 minutes or 15 minutes or so. So from there, you can export your 3D model. And then in there, you can use other software. In this case, I use a free software called Blender that you can do some post-processing. You can combine the segments into and do other things that you might need to do. Then you take that model and put it into the slicing software for the printer. And so we'll pull that up. And of course, open, stand by. So this is the software that comes with the printer, but it is also freely available. And you place your model on the build plate and set a whole bunch of parameters as to what materials you're going to be using and what slice thickness, what quality you want, etc. And I have the advantage of having a multi-material printer, so I can actually print this in a couple of different colors. Tell it to slice. And then you end up with the representation of the model here. And you can see it's hollow in order to save materials. But one thing that you see here is it's in midair. A lot of this is in midair, and you cannot start printing in midair. So fortunately, the software has built-in capability of doing supports where it will create a scaffolding in order to do that. And this is a breakaway scaffolding in order to effectively print it. All right, so we'll go back to here. And then from here, the whole printing process takes about, in this particular model for something this small, takes about 6 hours. So I did a little video of it, and this about a 2-minute long video here. So that is my printer. I name all my machines with the assistance of my children. You see on the top of there, we have the 5 different colors that we can print. And you see the print head moving left to right, that's the x-axis. You have the table moving back and forth, which is the y-axis, and then the z-axis is the up and down. And it's pulling in the filament into this metal piece down at the base that is heated up to about 220 degrees Celsius. It melts it and then just lays it down in a very fine line. And it changes filaments when it changes color. And as I mentioned, this process takes about 6 hours. So have a little time lapse here. Then we're left with the completed print on a flexible build plate that you then bend the plate to pop it off. And then release it from its supports. And there are more elegant ways to do supports, just not that I have set up. So we peel away all these supports, You do have to be careful. The model is a little bit fragile, and you'll see here I created an iatrogenic injury there to the infrarenal aorta that we're going to have to address in a little bit. I continue to pull off all the support materials here using a little cyanoacrylate, which you're all familiar with, Venaseal and Dermabond super glue. Was able to fix that iatrogenic injury. Super glue fixes everything. And I did a little pararenal work here. Continued to clean it up. And then it was at this point that I realized that I had accidentally avulsed the right internal iliac artery, had left it on the supports. So I had to do a little reimplantation there, again using cyanoacrylate, super glue. And then ready for the close-up. And so ultimately, this particular model, we have a kind of a trinket. We have maybe something educational for the patient, maybe a little bit for planning, but kind of gives you the overview of that process. Whoops, did I just? All right. So that is my my overview there. And as I said, I believe the next presenters will talk about other printing techniques that are a little bit cleaner than that, but that's the basics of it and how you could do it yourself at home.
Great, Dr. Carruthers. That was an awesome overview of 3D printing. And so next we'll have Dr. Nick Osborne, who will present on 3D printing for complex aneurysm planning and practice.
All right, thank you. I think that was a great overview to start on understanding kind of the basics of 3D printing. I'm going to admit that I am not a radiologist or a engineer, and my expertise in 3D printing is really in finding a good partner. So to start, I just have a disclosure of having served on an advisory board for Medtronic Aortic back in 2020. That's it. Nothing relevant to this talk. When we start to talk about the challenges of modern aortic practice, I think that a lot of us have seen kind of increasingly complex aneurysms. A lot of these represent kind of these endo failures, where we're talking about aneurysms that involve existing endovascular solutions which have failed over time, like this slipped aneurex graft in the middle of an aneurysm that now involves the renals and kind of paravisceral segment, or existing thoracoabdominal and paravisceral aneurysms that have never been treated that are in people who would otherwise not be considered candidates for surgery, and now we're trying to push the boundaries of treating them with an endovascular approach. And so I think really if you're kind of pursuing 3D printing and modeling, I think you have to have good partners. I have a great partner at Michigan. Dr. Wiedock is a radiologist who got in early in 3D printing, and he has really worked a lot with a lot of the different departments at the University of Michigan in 3D printing and planning. We use a lot of the 3D printing and fabrication resources that are available from the School of Engineering at Michigan, where they have a lot of commercial level 3D printers available that are able to be rented out for time and at a much reduced cost than what they would be in the community. So it's an excellent opportunity and gets to you having something that is a little bit larger kind of model than what you saw in the last one. So just to show a couple of these, this is kind of taking it from how Dr. Carruthers was showing you in developing these. You have to develop models kind of with and without the different layers. You develop these models and have to put them in CAD software to really do a lot of this work. As you're doing this, this is an example of that patient with the slipped aneurex graft that you can see, and you can see here we've represented the aorta in red. The thrombus here is in this kind of purplish color, and then the aneurex graft is in the light gray. You can see it in different projections here, and you can see with and without the shell being kind of an outer covering to allow us to 3D print this model. when we send it for the slicer, as Dr. Carruthers showed so nicely in his presentation. This is kind of what it looks like in the end. So here's a resin model. This is an elastic resin model that was printed on an industrial 3D printer. Since it's a large model, this is to scale. We had this as a 1-to-1 sizing to the patient's aorta, and printed it with a scaffold. It's actually printed with an internal scaffold in this case, and you have to core out that scaffold, which is actually a super tedious process of kind of cleaning it out, literally with some really large pipe cleaners like you'd use to clean the inside of real pipes. You just kind of slowly get all this soft, plasticky kind of waxy material out of the inside of the model. Once you do, you have a completely hollow structure that represents the aorta. In this case, we printed it with 3 colors. You can see in this case, we made the aorta clear, the endograft blue, and then the thrombus, the red color, and you can see nicely the different layers to this 3D print. I think in this case, we used it actually to practice working with residents and fellows. I think it's important to kind of teach skills. I have an interest in modification and custom modifications. I'm not going to get into that a whole lot in this talk, but we're able to kind of do some back table practicing in the boardroom in our offices and recapture these devices. And then what's beautiful about it is you can actually bring it into the OR. And under the C-arm, you can actually watch what it does when you deploy this, and you can practice doing this not in the patient. And so you can see here, we've got the 3D printed model. You can see the device has been delivered within, and then you can see here on the right, the still fluoro image where you can see the undeployed endograft with the branches that are all captured within the undeployed endograft. And I've just put a couple of clamps on here to mark where the origins of these vessels are, but you can actually see them in the next slide quite nicely in this description here, or in this video here, where you can see, looks like the video is not going to play, but as you can see the endograft, which has been partially deployed here, and you can see the viabonds, which are all now free, and you can see the origins of your renals and your SMA and celiac vessels. And from this, then you can start to plan how you're going to be able to cannulate these vessels, how you're going to be able to kind of actually perform this repair prior to doing it in the patient. And I think this is a nice way to kind of practice ahead of time, get your lay of the land, understand the topography and how the anatomy is going to change things. Of course, these models are not the flexibility of the aorta, and in some cases they're going to be more or less flexible, but I think it does really give you that opportunity to kind of think about it ahead of time. So just some more pictures of how we did that in another, in this case as well. Then in this case, an example of what we did the next day on the same patient. When we actually did this in the body on this patient, you can see it actually looks pretty similar to what we saw in that model on the previous slide. And you can see us cannulating, in this case, the visceral vessels before stenting them and extending our stent grafts down into those as well. And we went up with this repair that looked like this in this case. And I think the 3D printing ahead of time was able to give us a nice kind of confidence going into the case. Having kind of thought about it, we had kind of known all the angles, knew kind of all of where we wanted to land a little bit more precisely ahead of time. And it also just gave us a nice opportunity to practice the skills of kind of back table modifications and recapturing and then deploying these inside of the body. Here's another example of doing this in another patient, again with a failed endograft repair previously, who had a very large aneurysm. This is actually a 9-centimeter aneurysm that we 3D printed with the same flexible resin model. There's a slit in the aorta here so that we could clean it out completely because it was so large. It was hard to clean out the lumen of this one without doing that. But again, we did this to kind of think about how we were going to be able to cannulate. And in this case, the endograft actually was jailing the origins of the renal arteries, as you can see here. And our thought was whether we could actually be able to get any devices to track through these renal arteries against that endograft. And it helped us kind of in planning and thinking about whether we were able to perform this in this case as well. Other question I think that I've been interested in using 3D printing for is, can we use it in the OR actually to do back table modifications, not necessarily branches, but fenestrations on the back table instead of just eyeballing the clock face, or to try and put your fenestrations for your SMA and renals, or celiac SMA and renals, and do it more accurately. And you can use these type of printers for that. These are also available. These are a little bit more expensive than the one Dr. Carruthers showed, but these are actually quite affordable as well. This one is is the one we actually used for the models I'll show you. And it uses a technique called low-force stereolithography, which is a little bit different from the models that Dr. Carruthers showed, and it has a very fine resolution overall. Its limitation is really the size of these models, so you're really limited to something that's only about 6 inches in length and width. And so it's really not a very long model that you're able to make. And so you have to keep that in mind when you're making these, but this is actually something that you can use with sterilizable materials. So there are biomedical grade resins that you can buy that are sterilizable, and you can actually use those on the table. In this case, you can see here where we have this very short paravisceral model that we made. It was not straight line, but just actual to the form of the aorta. This is a one-to-one representation of the paravisceral segment of the aorta that you're able to use to try and think about planning. In this case, I just in my office here placed a cuff inside of here to show kind of how you could use this to kind of plan and site your fenestrations. And then once you've done this, you could remove the model from this and actually then perform your fenestrations before recapturing the endograft instead. So I think keeping this one a little brief so we have time for everyone. I think that I just want to show some examples of how you can use the 3D printing for some complex planning, education, I think, with the residents in terms of how you can use these to really perform the procedures ahead of time, and that we can use models that are actually radiopaque and you can actually see under fluoro if you want to see how these perform in the body. And then also for patient education, these models are super helpful when you have a patient and you want to show them what their aneurysm actually looks like, explain to them the difficulty, especially in these really complex multiple redo aortas. I think it's helpful to really explain and have them understand what these look like. And then, of course, I think one of the areas I think for really advancing this is in the back table customization and the ability to use these 3D printed models to perform back table fenestrations with a much higher accuracy than we currently do when we're just eyeballing these. So thank you very much.
Well, that was fantastic use of 3D printing for these complex aneurysm plannings. So we're going to move on to our next speakers, Dr. Fisher and Dr. Hirsch, who will discuss pre-surgical planning using the 3D modeling.
Thank you so much. And I'm looking forward to Dr. Hirsch joining in. There he is. So I wanted to start for just 1 second to show you a couple of the prints from the 3D Brody lab. This one is an aortic aneurysm. You can see the bifurcation here. This is one that had somebody had already stented, and there were questions of where there was stent fracture material issues and where the side branches were. So as you can see, the stent itself is in yellow here. And you can actually see exactly where the side branches are. And you can see the real size. So this is a resin printer. And then this one is an aneurysm that the clot in the, I'm sorry, this is a dissected aneurysm of the arch, which is more my part of the body. Here, where you can actually see the true and false lumen. You can see the blue has the clotted area, and you can see the location of the takeoff and the side branch as well. So this can be used for pre-surgical planning very nicely. I'm going to share my screen. And can you confirm that you can see the screen?
Not yet.
Not yet? Okay. How about now?
Good now.
Okay. So basically, I am a cardiologist. Dr. Hirsch is a body radiologist, and we came together trying to work on making surgery safer from my perspective for congenital heart disease. And there was a lot of requests from vascular surgery, and especially a couple of the people that do a lot of endo-aortic vascular repair, to have help identifying better some of the layout of where the side branches are and things like stent fractures, or for example, if there's a failed aneurysm repair or an area at the anastomosis that was changing, just understanding the exact size and shape better. So I wanted to give a little bit bigger overview of kind of how we're using 3D printing. And Dr. Hirsch really is the mastermind, so I want all input. But this is from the literature, just examples of how you can actually use printing to better see things as detailed as a valve structure. And this is one that had endocarditis. And you can see here the detail that we can get inside of the wall of the vessels. So for congenital heart disease, our aim is to restore cardiac anatomy to as near normal as possible at as early an age as possible. And many patients can actually undergo full correction, such as an ASD closure, but some disease is so complex, like a single ventricle, that palliative surgery is the only option. And then the patient is left with gross anatomical distortions. So occasionally the defects are not operable due to the complexity or irreversible pulmonary hypertension at diagnosis. And the personalized nature of their care moving forward leads to a lot of differences in the exact structural planning for their procedures. And that's where the need for 3D printing really came to light, trying to help with pre-surgical plannings, making surgery safer. Dr. Hirsch, do you want to present this slide?
Sure, thank you. So I don't want to go over a lot of information that was already, better presented as far as a summary of 3D printing. But basically, we get our DICOM data from essentially 3 different imaging modalities. Ultrasound is probably my least successful starting point. I've had better success with MRI, and I would have to say CT is the most successful imaging modality for at least starting out. The software that I use for creating models is something as a software application made by Materialize, and it's called Mimics Innovation Suite. It's basically the industry, I would say it's the industry standard for creating anatomic models. Mainly because of its FDA clearance as a medical software. The software suite is basically 2 software packages. The first software package is kind of like a 3D slicer. It takes your DICOM image set and allows you to mask out your anatomy. The companion application in that suite is a CAD program, and it takes those masked files and allows you to improve the mesh and make more of a printable model. So once we have it in that CAD program, we can make our STL models. One of the nice things about that program is you can take your finished design and actually import it back into your DICOM imaging data, and you can overlay your model on the CT scan, and it kind of gives you a last check to see how accurate your post-processed STL model conforms to your imaging. And then the last thing is you send it to the printer. The 3 printing modalities that we use in our lab are fused deposition modeling, which is we've already talked about. We have a stereolithography printer, and we also have a binder jet, which is the 2 models that Stacy showed you. That imaging modality uses a gypsum powder that's spread out layer by layer, and the slicer program uses inkjet technology to print out each slice of the model, and we get very accurate and colorful models using that. The finished model almost has like a sandstone sort of texture to it.
Sorry, just going to the next slide. So the uses in adult congenital heart disease really do translate well into vascular disease, where we need a detailed understanding of the complex anatomy, and this can help with pre-procedural planning. It can be ideal for device selection, selection of equipment. So for example, branch artery location, exact sizing or positioning of conduits. The training is incredibly important, as we heard in another talk tonight as well, where the tactile feedback and catheter manipulation can be done so that everybody's comfortable that the device choice is right and that the pressures are right and that people understand the placement and the appearance. Education where we can look at a collection of normal and abnormal anatomical variants. And also this can be used for education of patients. In a research form, it can be used for novel medical devices, and we all would love to translate eventually to bioprinting. So when we look at printing materials and types, this, for example, is the one that we just presented, but with the colors added, you can really use any colors. This is actually to size, this is a young child. This child does have, for example, pulmonary stenosis as part of their issue here. But you can actually see the anatomy very nicely in the relationships. Again, this is just a bigger view of the valve that I showed at the beginning. This material is different. We don't actually have this printer, but this is one that actually has a little bit more mobility. It's almost like a little bit of a rubbery print, and it does show the anterior and posterior mitral leaflets very well so that the leaflet anatomy can be better understood. And again, this is difficult anatomy for a lot of people to conceptualize. And as we develop more catheter-based techniques to deal with valve anatomy, potentially even a platform to practice the particular procedure. So this is an example of tumor imaging where we can actually look at a left atrial myxoma from a 3D echo print. Here's an example again from our lab of this resin-based print where you're looking down here into the pulmonary anatomy. Here you can see where a prior shunt was, and then the area never grew, where you have a pretty good branch PA stenosis. There is a coarctation, not too restrictive, but certainly a coarctation as part of this anatomy. This particular child, the issue here was actually the decision to pursue single or dual ventricular repair. And the size of the chamber was under question and discussion because of this large subpulmonary VSD. And it was decided based on partly on the model that it could be a two ventricle repair rather than a single ventricle repair. This one, I actually love this arch. This was one of the first ones that we did together. This one was actually done because of patient education. So this patient was a gentleman who had a TIA every time he got a low dose blood pressure medication. So somebody gave him 5 milligrams of lisinopril, he had a TIA. Someone else gave him 12.5 milligrams of hydrochlorothiazide and he had a TIA. And he was a young man, 48 with recurrent TIAs that presented, and then his initial anatomy and imaging showed, this part of this comeral's diverticulum, and the neck anatomy and brain anatomy looked fine, but seeing the area between the neck and the chest didn't show up on his first 3 or 4 CTs at different institutions because they were either CTs of the brain or the chest, but they weren't CTs of the neck or anywhere that connected the two. So, so this is certainly one that makes us realize we need to get the full anatomy, especially if we're seeing a problem where this patient certainly had subclavian steel from this atretic artery. And we had recommended actually taking the subclavian and connecting it to the left carotid and then removing the diverticulum and repairing that. And the patient declined. After we printed this and sent him home with his print for a little bit, he actually came back requesting surgery. And it just really made sense to him why he would need surgery. So it made all the difference. We had the same experience with a 1-day-old who had almost an interrupted arch, but a really severe aortic coarctation. Heard about this patient, we printed his anatomy. The treating provider gave it to the parents who took it home and came back and had decided instead of their taking their daughter home against medical advice to come in and have the surgery. So for patient understanding and care, these can be incredibly powerful models as well. For pre-surgical planning, this is the very large pulmonary artery of a patient who's actually having a stent implant on Wednesday. He actually has a very large, wide open pulmonary artery, but he has a collateral seal from a huge fistula from his left main that is draining into the PA. We were unable to cover it at the site of the left main or through catheter-based closure. So he is getting a novel FDA-approved, IRB-approved handmade stent to actually cover his PA and try to block the collaterals coming in. And the 3D imaging and dimensions and print were used in the formation of that handmade model. This is one from the Birdie Print Lab that looked at a patient that had extensive stenting, and there was a stent fracture and endo leak. And this was extraordinarily helpful in understanding where that was, where the side branches were, and where aneurysmal shape change started, and how to work with that. So for future directions, this is incredibly helpful techniques for incredibly personalized medicine and personalized problems, where the 3D printed model can be part of the patient's record. It can be available for teaching patients and providers, can be available as a second opinion consultation and for complex preoperative decision-making. Because of increased FDA regulation for printing standards and quality, this is really an evolving field. You know, how to continue to do this on an individualized basis, not in a commercial level, is very difficult. And I think a lot of the questions that are showing up in the chat box actually relate to that. So that'll be important conversation, because the FDA has released recommendations for standards and quality to make sure that the prints actually do in fact reflect the anatomy of the patient. In electrophysiology, we're using this a lot for placement of devices like the Watchman device, for catheter locations, for the coronary sinus understanding and placement of coronary sinus leads. Very helpful in that state for the virtual reality environment. But the biomaterial like resins are very helpful and just becoming more available. Also looking at EMG signaling embedded in the 3D models. The comprehensive 3D atlas of normal and abnormal hearts is incredibly helpful and something we're trying to develop for medical students, specialty, subspecialty fellow training. And also, again, we all want the potential to translate into biomaterials. And thank you for having us here today.
That was a fantastic discussion on pre-surgical planning using all these possibilities in 3D modeling. So we have 10 questions on the Q&A. Some have already been answered. So Dr. Kasavan, do you want to ask Dr. Dimitri's question, Dr. Levin's question? Do you see it? Okay, if not, in the Q&A box, go ahead.
Yeah, I see it. Yeah, well, it seems like a number of the questions kind of regard FDA clearance. And so, you know, as you move from using the 3D printing for educational purposes to actual prints that are going to be used for diagnostic and therapeutic purposes, at what point do you need to concern yourself with FDA regulations, whether it be for software printers or polymers being used?
Well, that's a great question, because the software that I was using, the Slicer 3D, you know, very explicitly says, you know, not for medical use, and so, you know, for that it would be educational type purposes. I think Dr. Hirsch had mentioned the software that he uses that is FDA cleared, and so I'll defer to him on that.
Yeah, as far as, I guess, making the FDA I guess adhering to the FDA quality management, it goes beyond that. It's more than just having FDA cleared software. It's kind of establishing an end-to-end program where you can assure that, that if you're making a vascular model that has an internal, say, just for example, an internal diameter of 12 millimeters, you can measure that on the imaging. You can create a model that says it's going to create a lumen 12 millimeters in diameter, but how do you prove that once it's printed that lumen truly is 12 millimeters? And how do you do that for every print that you make? I'm still sort of waiting for a good, I guess, use case, not a use case, but a good best practice from one of the leaders of our 3D printing community, like Mayo or Cleveland, or even Walter Reed, to kind of lead the way in how they establish, their quality management. And then rather than kind of reinvent the wheel, kind of see how, I guess, the pros do it, and then try to mimic that as best as possible. I think part of the problem is that a lot of 3D printing programs are like one or two people who are the champions for the 3D printing, and they're usually very busy with clinical practices. And so if you ask them, okay, where's your quality management system? You really need a lab, I guess, a lab manager who can take that on as a responsibility to ensure that happens. But again, I'm still sort of waiting for a good best practice to come out, and something that we can model a program after.
Dr. Hirsch, just a question, because I think this is something that I've definitely been interested in too, making sure that we're not kind of creating models that aren't realistic to what the patient has. Have you done any verification using CT scans of the models afterward to verify kind of, because you can CT your model, and then you can again kind of basically create the model from the model and kind of overlay the two and see if they are exactly the same. That's one method for verify. Have you done anything like that? I know we've tried that at Michigan, but it is kind of cumbersome.
I haven't. I try to use FDA cleared software when I can, and then I really like the way that Mimics takes your finished product and overlays it back on the imaging data. Because, as you know, anytime you post-process something, you change the morphology even slightly. And so it's really nice to have that check and balance before you print. But I think the last hurdle is to go from pre-printing to post-printing. And what's the best way to maintain quality standards, not just for each print, but over time as well.
Let me go and ask the audience question Q&A. So Dr. Levin says, how do you approach segmentation with using validated versus non-validated FDA software for clinical use? Any takers? You may have answered part of that question.
We made a decision when we started using these for more than education and teaching, when we started using them for clinical use, and to put Watchman's in to make sure the sizing was right. We made a decision to go to the FDA cleared software and to just buy the commercial license, which was it's a fortune, honestly. It's like $30,000 a year. We have the Mimics, and then Dr. Garcia, who does the prosthetics printing at Hopkins, he used the D2P, which has an auto segmenting feature. And has the VR as part of that. So those are kind of the ones that we have available. But we really thought long and hard, and we started out with the free type of software also. But we felt better, if we were using this to make clinical decisions, that we had the FDA cleared software. And I think if you're going to do billing, or use HIPAA protected information without getting rid of the identifying information before you load it into the software, that you're probably a lot safer using that software.
Great, because some follow-up question. Dr. Bill Concura says, do you know the billable codes you mentioned? I think that was probably referring to what you're discussing.
I can speak to that a little bit. There are 4 ICD-10 codes right now that have to do with billing for 3D printing, and I forget what they call it, but they're authorized, but there's no reimbursement associated with them. You can split those 4 codes into 2 parts. One is for printing a single model. Another is for printing multiple models. One is for printing a surgical guide, and one is for printing multiple surgical guides. So those are your 4 ICD-10 codes. And we're in the process now of trying to create like a consult service, like kind of how IR works, for providers who want to request a 3D model, and then once we get kind of that consult into Epic, we can hopefully marry it to the ICD-10 codes, and then try billing with it. So
great. So our next question comes from Michael Amendola. What is your current quality management system for the creation of these models? And I will refer to your most recent FDA position paper and town hall that states any 3D printed items based on patient imaging, I think we discussed this already, by a quality management system to ensure that the model accurately represents the patient's anatomy. Yes, I believe this has been answered.
Dr. Lynn, I also put in the answer there, I put a link to an article that I think is a really good article overviewing the different ways to go through verification of 3D models. I think it's super helpful if you're going down this road.
Perfect. Thank you very much. Yes, I see the link, Dr. Osborne. How about a question from Dr. Adam Johnson? Wonderful presentation. What are some things to keep in mind when importing patient imaging data into open source software to maintain patient privacy? Dr. Osborne, seems like you're typing something.
The biggest thing I think is I think Dr. Fisher mentioned it as anonymize before you put it in, but of course you have to be careful about any image patient data that's baked into the images. Usually they're not for CT scans, but for an ultrasound, and oftentimes there's patient information that's baked into the image data itself. So it's definitely a consideration, and where you're storing this. Is it encrypted? Is it liable to being lost and whatnot? So it puts quite a bit of onus on you to do that, but definitely a good consideration.
Thanks, Dr. Carruthers. The next question comes from Dixon Santana. Dr. Santana says, I see the model is to scale. I would imagine is related to the cost of so much material to do the real size model. I think somebody...
I think that was related to mine, and
yeah.
Or based off of the time it was typed in, but yeah, it was less cost and more the time of the print for me, because just that little one, which you see right here, I have on a little electrical wire stand. That took 6 hours to print, and if I were to print it full size, this is I think half scale, maybe a little smaller. If I were to had to print it at full scale, it would have been that much longer. And, so it was mainly a time thing rather than a cost. But for the material jetting, I'll defer to the other presenters. But the other modalities, those media are quite expensive. The filament for my printer is $20 for a kilogram. The material for a jet, one of the material jet things, is like a lot more. I don't know exactly how much, but somewhere on the order of like $500 or $1,000 for a kilogram. Correct me if I'm wrong. If anyone who knows better.
I think it depends on what you want to use the model for, what you're scaling for. I think in general, if you're doing this, making it to scale to what the size of the patient's anatomy is helpful. Sometimes if you're looking at at a structure that you really want to get a good look at, you might actually double it and go 2x to see really well what you're looking at and get a better understanding of that anatomy, not necessarily for anything more than planning. But I think that can be really helpful. It does significantly increase your cost if you're doing that. The time to create the models and everything else goes up. So you have to think about that. But I think it's helpful as you go through this not to always just make one model, but to make several models, one at regular size and one sometimes at a larger size.
Great. So next question is Dr. Ravi Ambani. Great talk. How do you decide which patient you're going to print a model for to explain their anatomy better? And he uses them for similar reasons at his own institution. Any takers? Dr. Fisher, Dr. Hirsch?
Yeah, I'm happy to take that one. So for me, it's really patients that we have questions about. For example, if there's, in my world, you know, a VSD where you can't really see the back very well, and we're struggling with the anatomy, using the 3D aspects of it can make all the difference. And then it can really help to have the surgeon have it in the operating room so that they can actually twirl it around and they can see if they've actually seen all the aspects of the hole in the surgery. For the vascular surgeons, it's been a question of ones that they still have questions with, or they're really not sure where the side branch takes off in relationship to a stent. It's ones that we really need to take a deeper dive. Or again, for the educational parts, it's been family members that are hesitant or really don't understand, or we're having trouble getting through. Or it's ones that we're trying to explain to, for example, a student or a resident or a fellow, and you can see that it's not clicking. So for those patients, it really becomes pertinent that we decide this is going to be helpful. In our heart conference, we have a multidisciplinary congenital heart conference once a week. And we actually have, as part of our discussion, would printing make a difference in anybody's view? So in that presentation is surgery, interventional cardiology, clinical cardiology, adult and pediatrics, radiology, and genetics. And we all have the discussion. And then a couple of them have been ones that people just want for illustration. For example, we have a request for a patent ductus, just for somebody to actually blow up and have an example of this is what it is, and this is what we would do in your preemie, but 5 times the size. So that somebody could actually understand from a parent's perspective what they're getting into, what's there, what the problem is, and that there actually is a problem. So the ones that we printed are selected by clinicians that have a question.
Great. So this question is also for you from Dr. Levin. Do you use EP maps for printing?
So we're just starting to actually decide how we can get EP maps into the models, and that is not a done deal at this point.
Next is Sarah Holtzman. She is a medical student interested in pursuing vascular surgery and research in AI and vascular modeling. What can a medical student do at this stage in their career to prepare a trainee practice environment that relies on such technology, like 3D printing, etc., beyond learning basic programming skills? Nick or Dr. Hirsch?
Well, find a mentor, like preferably local, that you can really learn from, someone who's doing something that you're interested in, because it's nothing beats kind of one-on-one learning. You don't necessarily need to know programming per se, but you just need to kind of learn the techniques and the basics. And getting your own 3D printer is the best way to do it. And that's how I did it. Is you get it, and then you don't just print models that you download off the internet. You design your own things, or you create your own scans. Create your own models from your scans. And there's just like any medical training, there's no substitute for just practice with good mentoring.
Awesome response. So next is Dr. Oliver Lamy, who would be part of the best multidisciplinary team to set up a 3D printing core facility or lab? Dr. Hirsch?
You really, I guess the bottom line is finding somebody who wants to do it. And, I find that a lot of people, well, just two quick examples. I'm a radiologist, and I started my lab with a couple other interested people also in radiology, and then Stacy kind of joined us with cardiology. But over in Hopkins, the champion for 3D printing is actually from the medical arts department. But you really got to find somebody who's interested in it, who wants to kind of keep the ball rolling forward, and then making a connection with providers is also key, because I don't think I've ever printed. I haven't printed a lot of models that I've wanted to print. It's always people coming to me and say, "Hey, can you do this? Can you print this?" It's basically the surgeons coming to you, "Hey, this is a use case that I think might be interesting if it was printed," and that's interesting to me too. And so, we kind of run with it and try to make a model.
Well, Jeff, our most popular model has been the pig heart.
Nice.
We've had so many requests for the human pig transplant, because the anatomy is so unusual and the model really demonstrates it beautifully. So every time we make a model of the pig heart, it's gone. I don't even think we have one left for us.
Well, that's great. So we have a couple comments. Dr. Amendola, great article. Dr. Osborne, by our group in the VA who's working closely with FDA on a best practice. Okay, thank you. And then Dr. Abani, in Cleveland, with every anatomic print, we print a small cube that has exact measurements, dimensions that we then compare to use it as a quality metric. Okay. Lots of a question. Happy to share papers regarding CT scans. So there was some link to that. So Arya has a question for Dr. Osborne. However, he needs to go to another meeting.
I can answer quickly for that
yes.
one if you want to do this. But
yeah.
So
yep,
I haven't used the flexible models in actually creating the fenestrations or branch grafts. It's more for practicing more than anything, but I think it is a challenge, since nothing really is the same as the human aorta. None of our materials that we've made are at that, anywhere close to the elasticity or anything that we can use for that and recreate it. So I think you always have to have that in mind. I think the benefit of the flexible elastic resin models is that you can create a semi-flexible model that you can use and kind of practice with either residents or fellows or medical students, and you can also get a little bit more practice yourself ahead of time. But again, I wouldn't use that for actually planning out where your fenestrations are going to be. I don't think that it's I wouldn't use it for that personally. Those models, I think there are other those short segment ones like I showed. I think that is a little bit more accurate when you're having a very short segment that you print that you want to create the fenestrations off of. I think that's a little bit better for that personally.
Great, thanks. Lots of great questions. This one is from Dr. Andrew Gonzalez. 3D printing is certainly compelling from safety and educational perspective. However, if it is not compensated, there's an institutional financial disincentive for adoption, either because of a high barrier to entry or for a marginal value for doing some cases instead. This seems like something that SVS, AHA, ACC, ACR should take a tackle joint fashion. Any current effort on that, on 3D printing? Does anybody know?
I do not know.
I do not know. I don't think SVS does. 3D printing is a lot of things that we do on our own from an institution perspective. Usually comes out of the Innovation Center or some other center.
Right, for us, it's come from a wonderful family donation. We decided to use philanthropy to start this and to try to work with us. And for example, during the pandemic, this family did allow us to broaden our use, and Dr. Hirsch made some parts and things that seemed to be very helpful during the pandemic that were on short supply. So we have tried to use this to the best of our ability, but we haven't been able to find other funding for it.
Great. And the next question is from Dr. Michael Amendola. VHA has created the first fellowship in 3D printing and surgery. All students and residents are welcome to apply for the VHA-based fellowship in 3D printing. That's nice. So www.va.gov/innovation ecosystem. And then also Dr. Roy Fujitani, what material do you find best to mimic the real-world flexibility and feel of anatomic structure, i.e. skeletal morphism, skeuomorphism?
I don't have experience with any of the resins or other things. I don't know if Dr. Hirsch or Dr. Fisher do.
I'm kind of limited to what our printers have. So I haven't really worked too much with the flexible resins, even though the SLA printer we have does print two types of flexible resins. That I think part of the problem is they're hard to print with the supports, and you really can't go very big with them. They're really I think short segment vascular lumens are kind of the best success I've had with flexible resin, but.
Okay. I did cut and paste one of the articles requested by one of the attendees. Other than that, are there any further questions or anything from the panelists you would like to discuss? I think we did answer all the questions that I've seen listed in the Q&A box. If not, please let me know. You can always
Yeah, I wanted to congratulate everyone on a very informative presentations. I had a question about selection of a 3D printer for the vascular surgeon. And so obviously the question is open to all the panelists, but Dr. Carruthers, you may have a little bit more insight. The lab in which your group printed the N95 mass, you guys used a commercial consumer grade 3D printer. You could essentially, like you mentioned, you could buy it off Amazon. It's about $1,000, and it's not the least expensive printer. From the perspective of a hobbyist who performs your 3D prints on your own, do you have any recommendations about different consumer 3D printers, features that you look for in selecting polymer types, and other potential risks, rather benefits or drawbacks?
Sure. The printers I have are made by Prusa, which is the kind of de facto gold standard for the FDM printers. They're not the most expensive and they're not the cheapest. They run around $750 a piece, and they come unassembled. So it's a little bit of a process to put them together, but the directions are very clear. And I'm not making this up. Each one comes with a bag of Haribo gummy bears with instructions in the instructions on when to eat the gummy bears with each step. I'm not making that up. They are very well supported. They are, so many out there that you can find lots of support if you run into issues. They're upgradable. Like all the computer stuff I have attached to it is Raspberry Pi computers, like these little tiny computers that run Linux, and then the cameras attached to them. So it's a kind of a nerd's dream for that sort of thing. If you want more of an out-of-the-box things, there are plenty of options for that. One of the more affordable but still reliable brands is called Ender, E-N-D-E-R, which is you can get a decent one for $300, $300. The feature set is all similar, but they all kind of print in the lower end ones, all print in the same materials. The either PLA, which is the starting one, or PETG, which is the one that I use the most, or ABS is what Lego is made out of, but it tends to be pretty finicky. But they're definitely affordable options, and like I said, it ranges from ones that are kits for people who like to tinker and put things together to things you just take out of the box and work. They work on their own. But again, the biggest ones, Prusa and Ender, are the two bigger names.
Wow, that was great. It looks like we're coming to an end of this webinar, and 3D printing is becoming the largest disruptive technology shift since the internet. It is fascinating to see where technology will take us in the future, and definitely something to look forward to. During the last hour or more, we just learned about a new and exciting three-dimensional printing technology in vascular imaging from the expertise of renowned physicians and innovators who could affect your current and future practice. And I've enjoyed our open discussion about how to take better care of our patients by various innovations. So our next step will be to strive for improvement in vascular care using these modern technologies. So please stay well, stay safe, and let's innovate. And thanks for listening. Have a great night.